Hello, and welcome to our conversation today. We're going to talk about lupus disease flares. From a patient's perspective, they cause distress. They also can lead to unplanned doctor's visits, visits to the emergency room and hospitalization, out-of-pocket costs, and poor quality of life. From the physician's perspective, we always want to get our patients who have lupus into remission. However, these lupus flares lead to more organ damage. We hate to see our patients suffer, and they also increase mortality rates. Today, we're going to define lupus flares. We're going to identify tools in the physician's toolbox that can help measure and predict flares and talk about their management as well. My name is Dr. Donald Thomas, and I'm an Associate Professor of Medicine at the Uniformed Services University of the Health Sciences in Bethesda, Maryland, where I also teach at the Walter Reed National Medical Center. I love to teach other healthcare providers about systemic lupus and how to manage them, as well as empowering patients and teaching patients. And that led me to write a book called The Lupus Encyclopedia, a comprehensive guide for patients and families. I am in private practice with Arthritis and Pain Associates of Prince George's County in Greenbelt, Maryland, where every year I work with hundreds of lupus patients and help them win their battle against systemic lupus. I am absolutely thrilled this morning to be joined today by the renowned clinician and researcher, Dr. Chaim Putterman. Dr. Putterman is a rheumatologist who has devoted his career to systemic lupus and other autoimmune diseases. He's a professor in the Department of Microbiology and Immunology, as well as the Division of Rheumatology, where he is the previous chief at the Albert Einstein College of Medicine in the Bronx, New York. I constantly read everything I can get my hand on about new journal articles about lupus, and Dr. Putterman's name continuously pops up. He has written and contributed to over 200 publications. His special interests include the identification and characterization of novel mechanisms of disease. He has helped discover and evaluate better biomarkers that help more accurately diagnose lupus and help measure its disease activity. He has helped discover and evaluate newer treatment approaches. And on this note, some of his most exciting contributions are his bench-to-bedside translational research, where his work on BTK inhibition and anti-CDK inhibition for lupus are currently in human clinical trials, and we look forward to hopefully seeing better and positive results. Dr. Putterman, thank you so much for taking time out of your busy schedule and being with us here today.
Thank you very much, Dr. Thomas. That was a very kind introduction. As is often is said, I wish my mother could have heard it, but I do appreciate the introduction. I also appreciate the opportunity to sit with you today. You said you're a teacher, and I'm happy also to learn from your extensive experience.
Oh, excellent. And your mom would be very proud. Today, I'd like to talk about several things. I'd like to talk about how we define lupus flares. I'd like to talk about why does this matter to me as the physician and to our patients, and also how do we identify and manage these flares, and is there any possible way to even predict them before they occur? So Dr. Putterman first, what is a lupus flare and how would you define it?
So you mentioned on multiple great questions, and I'm looking forward with you to exploring these really very critical issues to the health of all lupus patients. So let's start with a definition of flare. It really is not a single definition. I think it's clear that rheumatologists and people that have a large lupus practice tend to have their own definition. For myself, I like to use or base my definition off of Lupus Foundation of America, LFA definition from a few years ago, which defined a flare as an increase in disease activity involving one or more organ systems that manifests itself either in new or worse clinical signs or laboratory abnormalities. The change in this disease activity needs to be significant enough that a provider considers it such and also at least thinks about a change in therapy as a result of this flare.
All right, that's an excellent answer, and I'm really glad you brought up about the Lupus Foundation's definition because that is what I also like to use. I think it's very, very nice and to the point. What are some of the symptoms of a flare that a patient may experience?
Well, as we both know very well, and our rheumatology colleagues, there's really no end to the presentations and to the manifestations of lupus patients. They have disease in most every system. And because the disease is multi-system, the flare will manifest it in multiple different different types of presentations, types of signs and symptoms. So there's really no one single way of saying if you have that manifestation, you have a flare. Rather, it can be a involvement of the usual organ system that this particular lupus patient has, or a new manifestation. They never before had skin disease, and now they have a new skin rash, and that might be a manifestation of a lupus flare.
In my mind, when I think of a lupus flare, I think that many of us oftentimes think about the symptoms that are in the classification criteria. For example, the malar rash, the oral ulcers, hair loss, pleuritic chest pain. But one thing that I think that draws me and people like you to treating lupus patients is the diversity of our lupus patients and how complicated and complex they are. And oftentimes our patients don't follow the textbook and always have these classic lupus symptoms. They can have other things such as uveitis. Do you have any examples of some flare-ups that you have seen before that don't follow the classification criteria that physicians should think about?
So fever is not one of the lupus criteria, and that absolutely could be one of the signs of flares. If you would ask our lupus patients, as you do, the number one complaint that they will have, subjective complaint that accompanies objective evidence of disease activity, they will say fatigue. So fatigue doesn't make it in the criteria, but that there are many reasons for fatigue. A lupus patient has multiple reasons to be fatigued that is not related to disease activity, but definitely fatigue can accompany disease activity as well, even though it's not part of the standard criteria that we use for lupus.
I absolutely agree. I'm glad you brought up fatigue because many of us don't bring it up with our patients. And I think one reason for that is that it's such a hard symptom to treat, but it's so important to address with our patients. So thank you for that. What are the differences in flare severity and how do these different severities impact your treatment options?
So I like to divide lupus activity in general, and flares fall under that rubric as well, as mild, moderate versus severe, or mild versus moderate, severe. And what defines a moderate to severe disease activity or flare is something that is organ or life-threatening. Anything that is organ or life-threatening, I will define as a moderate to severe flare. I think that even mild flares can be very bothersome to the patient, need treatment, but perhaps the urgency in which we approach the patient, or the intensity of the initial treatment, or how quickly we reach for pharmacologic versus non-pharmacologic options might change according to those different definitions. Definitely, if we're looking at a severe, moderate, or severe flare, we need to proceed very quickly.
And so one common scenario I like to bring up is, let's say that you have a patient who thinks she's doing fantastic on treatment. However, when you talk to her closely, you find out that every month around the menstrual cycle, she has a few days of pain and swelling in her PIP joints. She's very fatigued and tired, has a few mouth ulcers, which don't really bother her very much. But what do you think about this patient and what would you recommend to clinicians?
I thought we decided that you're supposed to ask me the easier questions, Dr. Thomas. So that's of course a great question, and we are perplexed and wonder what's the right thing to do about these patients as well. I like to see the patients during the flare. I would encourage a patient, definitely if this is something that happens relatively frequently and that lasts more than a few hours, I would like to see the patients. Not every, as you well know, not every musculoskeletal complaint in a lupus patient has to do with their lupus, right? Women during their, as part of hormonal changes might also develop edema, and what the woman is complaining about is actually due to edema that is worsening a carpal tunnel syndrome. Just as an example, has nothing to do with lupus. I'd really like to get a feel of how bad she is while these complaints happen, how objective is the swelling, is there synovitis, or it's just a soft tissue involvement, and then work with her and see how much this bothers her day-to-day life and how much do we think that there's accompanying damage, right? The woman, our patient, could be complaining of musculoskeletal complaints, but every time this happens, there's also a dip in her platelet count or an increase in her proteinuria, and we'd, of course, treat that very differently.
And you bring up a fantastic point. Not everything that happens in our lupus patients is due to lupus, as we rheumatologists certainly know, and it's so frustrating for when our patients go to the emergency room that oftentimes they'll blame everything on lupus and treat them with steroids, and we just hate to see that. For example, the dermatologic issues that our patients get oftentimes are not lupus at all. They could be eczema or other totally unrelated things. Hair loss is oftentimes not even really lupus related as well. So I like to rely upon a good dermatologist who's very well versed with lupus to help assess my patients.
Right.
So thanks
Very
for
helpful.
adding into that.
Yes, correct.
So what are the ramifications of a flare and repeated flares?
So that is something that we are coming to understand, rather than just a flare being an isolated period of disease activity, which necessitates increased treatment. It leaves a mark. It leaves a mark in the form of damage. So we like to think of our lupus patients, as you know, is there's disease activity, and there's also something called a damage index, or accumulative damage over time, which is there's no active lupus at the time. However, after repeated injury in whatever organ system, there's something left, and that organ, the tissue, is not working as well as it would without without the effect of the cumulative flares. And therefore, when we think about treating flares, my practice is not only to think about the patient's current symptoms, but to think about whether there's cumulative damage over time. So we need to think in our treatment and to direct our treatment to preventing also this long-term cumulative damage. I think that as rheumatologists, we've become greedy in a way that the biologics have taught us that our goal should not only be disease control, but rather our goal should be remission. And we really want to achieve remission. Patients with lupus who achieve remission, however you define it, or achieve something called low disease activity, LDA, those patients over the long term do much better. And the reason they do much better is because they have less flares, and every flare that they don't have leaves their organs and tissue in a much better situation than it was had they had that continued disease activity.
Yeah, I totally agree with you. And both of us have been rheumatologists for a long time, and we can remember back in the days when we were taught that treating lupus arthritis, our goal was to help our patients feel better. That was the end goal. Today we know we want to get that patient into remission. And just a couple of years ago, I'm just reminded of a very nice study where they looked at hundreds of Latin American lupus patients, and they showed that even mild flares, if they have frequent or repeated mild flares, that leads to ongoing permanent organ damage. So we do need to strive for remission, and I'm so glad you brought that up. What's in our clinician's toolbox for determining if a person with lupus is having a flare?
So, we're of the generation that still listen to patients and examine patients instead of typing on the computer. So I think the most important instruments that we have, of course, are the history and physical exam. And knowing the patient and knowing the patient's history and understanding that lupus flares tend to be or are often stereotypical. And it helps to know a patient's history, and the patient will tell you, as your patient did, once a month around her menstrual period, she has PIP swelling, or the patient will say, oh, that's how my lupus flare feels, and we need to listen to our patients. That's a wonderful set of tools. Our five senses, listening to the patient, examining the patient, will often help us decide whether what we're seeing is a disease flare, and if this increase in symptoms, signs and symptoms, is due to lupus. That is, of course, one major category, but we also need to use the laboratory, and we could talk more about that if you would like.
Very nice. Now, one thing we use in clinical research, and certainly you have used a lot, are actual quantitative measurements, such as the SLEDAI for disease activity, the BILAG for flares. Do you see any utility whatsoever for these in clinical practice?
That's a little bit of a difficult question because as a researcher, as a clinical researcher, these instruments are vital. They're instrumental in quantifying disease activity, and you can't imagine doing a well-done clinical trial without having a multiplicity of instruments, both objective as well as subjective, patient-centered or physician-centered. All these are really very important. As for some of those scores that you mentioned, some physicians find them also easy to use in clinical practice. And they find that they're very helpful. This is definitely people that are experienced. See a lot of lupus patients were trained and are experienced and could fill out a SLEDAI very quickly. BILAG is a little bit or much more complicated and takes much more time and is not usually used clinically. We like to use SLEDAI, and again, I think this is something which is sort of leaking from the RA field, where now filling out DAS, the disease activity score, is routine because we want to treat the target. Such a move, I feel, is also happening among our lupus patients with the biologics that are being introduced for their treatment.
Yes, and I used to be in the camp of not recommending the SLEDAI score for clinicians in clinical practice, but as you mentioned, the more we talk about it, the more we think that it may be useful. For example, that patient I mentioned who flares up during her menstrual cycle, you bring her into the office, you notice that she does have synovitis of the PIP joint, you notice an oral ulcer on her hard palate. Her labs show that she has an elevated anti-double-stranded DNA and low complements. If you add up the score on that patient, she has more than 6 points on the SLEDAI score, which is moderate disease activity. And I think that many rheumatologists would actually consider her as having mild flares during these monthly flare-ups, when in fact she is having moderate flares, and that should really increase the interest of the rheumatologist in trying harder to get that patient into remission. So I do think it does have some utility when before, maybe a few years ago, I did not think so. But it does take some learning and some on the part of the rheumatologist to learn how to do that. And one thing that frustrates me, Dr. Putterman, is that I wish I had a better way to reliably and accurately measure disease activity in my patients. When I check anti-double-stranded DNA levels and C3 and C4 complement levels in my patients, I am so happy when I had that patient where those reliably tell me how that patient is doing. But in that patient who complains of joint pain, severe fatigue, and never has a high anti-double-stranded DNA and low complement levels, That can be so frustrating to me as a clinician. What are your thoughts on this type of patient, and do we have any other newer types of laboratory technologies that could help us out with this type of patient?
Um, I'm a big believer in anti-double-stranded DNA and following anti-double-stranded DNA in complement levels. We believe that they need to be a routine part of the follow-up of any lupus patients, even those that are not symptomatic at the present time. For many patients, they are reliable and accurate. However, I was careful, as you were, to say that only for many patients, and there are many other patients that for which these indicators are not sufficient. I would put those patients in two major categories. One in which these markers are not sufficiently sensitive, in which clearly our clinical acumen is telling us that the patient is undergoing a flare, but without change of complement. And perhaps that patient that you mentioned before, a similar patient might not have a change in their complement levels, maybe just in their anti-double-stranded DNA, which would be sufficient, but some of those patients won't have a change in either indicator. Another group of patients are those patients which are serologically active chronically. We have a group of patients followed in our practice in clinics in which they always have a high anti-DNA, and changes in the anti-DNA don't happen often in these patients. So it is more the change in these markers which we follow and which is important for us. Again, anti-DNA and complement are widely available. They're excellent. They'd be even better if they'd be more widely used and if we would correctly know how to use them and understand their limitations with imperfect sensitivity and specificity. As for additional markers, laboratory indicators of flare, I've seen some people use the sedimentation rate, the C-reactive protein. I think they're very non-specific and they're not useful for that purpose. Something which we have been involved with developing and we see increasing uptake in is a modification of complement measurements, and that is CB-CAT, cell-bound complement activation products, in which by flow cytometry, finding and identifying complement split products on cell types, on erythrocytes and B cells, might be an earlier and more sensitive indicator of flare.
I'm glad you brought that up, Dr. Putterman. One of my favorite papers you wrote was your 2014 paper about CV caps. And in my practice, we have started to use this, and it's just fantastic how so many more of our patients can be positive for erythrocyte bound C4D CV caps, and how that can fluctuate with disease activity. And we see that positive in our patients who have normal C3 and C4 levels. So we are seeing some advances over time, and hopefully that will get better and better over time. If you suspect an increase in disease activity or a flare, what strategies do you use to treat the flare, and what kind of strategies do you use to prevent future flares?
I think context is important in this case. And I mean, first of all, you want to look at that individual flare and decide if it's mild versus moderate or severe. That sort of, as we said before, determines the urgency in which you approach this particular patient. Another very important piece of information which I use in deciding how to treat the patient is how frequent are these flares. A patient that has frequent flares is clearly not doing well with their baseline therapy. Either they're not on any baseline therapy whatsoever, or it is not sufficient enough to cover them. Frequent flares is, again, an indicator to me that the baseline, not only treating the flare in front of me, but also treating the patient's baseline activity. As for the flare in front of us, if we do think that the patient in general, is doing well and rarely has a flare, and the flare that they have is easily treatable, I would try first to use the non-pharmacologic options. You're somebody who very much is aware of those and encourages patients to use it, and maybe you should share some of your experience with that. And only if necessary, we want to get to the pharmacologic management of that particular flare.
Yeah, I totally agree with you. And you're right about the non-pharmacologic options. One thing that has always fascinated me about lupus is it's just not a disease of taking medicines for management, but there are so many things that can trigger patient's disease to be more active, such as ultraviolet light. And it just takes small amounts. Dermatologists have shown us that just indoor lighting, ultraviolet light can cause lupus flares. And so I do teach my patients to use LED light bulbs in their house instead of fluorescent or incandescent bulbs, using sunscreen all the time, eating an anti-inflammatory diet. There's so many things that patients can do for themselves that I've written a handout called the Lupus Secrets that has these lists of do's and don'ts. And I like to give this to my patients to remind them to do these things to help with their disease activity. And one thing I'd like to add, Dr. Putterman, is something I feel very strongly about is the use of hydroxychloroquine drug levels. I still remember being in Venice when Dr. Michelle Petrie got up and she showed us some really startling data where she started to check hydroxychloroquine drug levels in all of her patients, and 45% of her patients were not taking their medicine. And so each time she saw them, she would show them the results, and over time, she got it to where 85% of her patients were compliant and adherent to taking their hydroxychloroquine, and disease activity improved in her clinic. And so since then, in every single patient I see in my clinic who is not in complete remission, I check their hydroxychloroquine drug level, and I did the same thing as Michelle did. And today, most of my patients are in remission and low disease activity. And I saw the same thing as her. Many of my patients were not taking their medicine. I would have patients sitting on the examination table, and I would say, "Are you taking your medicine regularly?" And they say, "Oh, Dr. Thomas, I swear, yep, I'm never missing a dose." And then their level would come back at 0. And I would show them the result. And I think as our patients just want to please us, they just want to tell us things that we want to hear. And I really think it should be the standard of medical care for rheumatologists to start using that. I would highly recommend to any rheumatologist watching this video clip to please start checking hydroxychloroquine drug levels. You'll be amazed at how much better your patients will do. And I'll get off my soapbox out about that, but I really do think it should be the standard of care for all rheumatologists in the future with our lupus patients.
Your soapbox is a shared soapbox by all of us. I think that if there's one factor that we would all love to change in our lupus patients and the other patients that we treat is the issue of compliance. Many patients, as we know, the numbers change. They get up to the 45% that you mentioned, sometimes even higher. Don't take the medication at all or take it incorrectly. And often our first instinct as physicians, if something works partially, is to give more of it. And your patient with hydroxychloroquine is maybe not doing so well, and you want to give them more than maybe it's recommended. The first thing you need to do is to see if they're taking it in the first place. And if they're not taking it in the first place, that's where we need to be starting. I think that following levels of medications, whether it's for hydroxychloroquine or the other medications we use, is becoming increasingly employed as a very important tool in understanding why the patient has the disease activity when they do. And maybe even more important, as you mentioned, it really helps the communication with the patient and showing the patient that maybe before changing a medication that is perhaps less dangerous and more effective to something which is more dangerous, he or she could actually take the medication that we're prescribing, or understand what the barriers are. Why are they not taking? Oh, I can't get that from my insurer, or that medication causes me to have nausea. Whatever the reason is, we could work much better with our patient if we understand the reasons for the non-compliance as well.
And on that, Mark, I'd love to share just a very short, quick story with you. I saw a patient of mine who I've been following for 2 decades, and she always follows my lupus secrets, that list of do's and don'ts I told you about. And recently she had a flare, which I was shocked about. She hadn't had a flare in a long time. I measured her hydroxychloroquine drug level. It was very low. It was in the 200s. So I sat down with her. I said, what's going on here? Usually, very good with taking your medicines. And she said, Dr. Thomas, on my bottle of pills, they put on there that I have to take my hydroxychloroquine with food. I said, I wish you would have sent me a message on the patient portal about this. We could have talked about it. You don't have to take it with food as long as it's not upsetting your stomach. And so she started taking it regularly. She went back into remission, and they got the most lovely card from her. The card said, Dr. Thomas, I love having you as my doctor, and I really appreciate it. And all of us get these cards, which we love as rheumatologists. But she said on there, Dr. Thomas, I want to live a long time, and no one in my family has lived past the age of 60 years old. Well, my patient, she's 73 years old. And that's just amazing to us as rheumatologists. We have all these patients in their 70s and 80s, which was unheard of a couple of decades ago. And it's these kind of tools that are helping us to be able to do this. So I'm glad you brought up about how we can talk to the patient about these drug levels and find these things out and help them out. Right. Next, Dr. Putterman, when I do my history, my physical exam, my laboratory test, I get a nice snapshot of how my patient is doing right here at the moment. However, are there technologies that can help us predict flares before they even occur?
That's an excellent question, Dr. Thomas. Maybe before I answer that, let's emphasize, why is it important to predict flares? Why would we love to have such a tool? I think that having an accurate, reliable and reproducible tool to predict flares in lupus patients would revolutionize the care of our patients in many different ways. If I would know today with a reasonable degree of certainty that my patient is in a flare or is going to flare, we would start thinking about compliance. We would start emphasizing the non-pharmacologic option. We would start going through the medications and making sure that the patient is doing it correctly. We would recommend to the patient that maybe it's not a good idea now to go for a 3-month vacation without seeing a rheumatologist, but they should see that patient next month. And for some patients, especially those patients that really got in trouble last flare, it would be a great idea if we could already start treatment. I like to quote an article, which I'm sure you're familiar with. It was published in The Lancet, I believe in the mid-90s, in which, based upon increasing anti-DNA antibodies, which, as we mentioned, is not a perfect indicator of a flare, patients were randomized to just follow up or already to institution of steroid therapy. At the end, those patients in which flare was being predicted based upon anti-DNA antibodies, those patients had many fewer flares, but their surprise was that they ended up getting less steroids over a year or two. And the reason is that a stitch in time saves 9. If you could give, a flare is coming, you could get away with a small amount of steroids for a short amount of time, as opposed to waiting until the patient flares, and then we have to blast them with mega doses of salomedrol. So really predicting a flare is one of our dreams as a rheumatologist, and I think there's some movement, and we're starting to see such tools that might help us with this.
Yeah, that'd be a wonderful thing, and that's on my wish list as a rheumatologist who takes care of lots of lupus patients. Well, Dr. Putterman, your insights and recommendations regarding lupus flares is greatly appreciated. And do you have any other additional comments on anything I might not have asked about?
So I do think that there's some excellent progress to share with our audience regarding flare prediction. In some patients, excuse me, sorry about that. Some patients, close monitoring of anti-DNA and complement levels will help you predict a flare. Again, it's not the first time you see a patient, but certain patients, you know by then, you follow them in your practice for 3 or 4 years, you know that every time they flare, the month or two before, they start to move their anti-DNA and complement levels. Those are the patients that you need to do something. Doing something depends on you and the patient and the context, but follow them more closely, bring them into clinic in a week or two, change their medication. It's probably a good idea to prevent that flare. On the other hand, many patients, we can't use those parameters to predict flare. There's some evidence that CB caps might be helpful in that regard. Those studies are currently in progress. I hope that there will be positive results. We would love to see a tool that would allow us to predict flare. And there are other companies involved that are looking at multi-mediator panels of inflammatory mediators as a way to predict future flare. If you can measure a certain array of inflammatory markers, cytokines, and other mediators, that might allow you to predict a flare in the subsequent weeks or months. And again, that would be very helpful for us.
Yeah, that'd be very nice. We know at this point in time, the only thing we have to go by is when we see that trend of increasing anti-double-stranded DNA level over time or decreasing C3 and C4 complement level, that could potentially predict a flare, but we can lose months in helping our patient out. So if I had a way to measure it and predict it, in one blood test, that'd be fantastic. Well, Dr. Putterman, thank you so much, and I really do appreciate your time today. And I hope you and your entire family stay safe.
You as well, and thank you. It was a great conversation, and I hope we'll help our patients even more than we're doing now.
Thank you very much. Bye-bye.